Welcome to the Aging Boomers. I'm your host, Frank Sampson, and of course, on this show, we discuss so many of the issues facing boomers, their parents, and what we know, of course, as an aging population. I'm very excited about today's guest, but before I introduce him, I'd like to let everybody know that today's show is sponsored by Senior Care Authority. Senior Care Authority is a professional senior placement and elder care management organization that has a national network of advisors to help in determining the right path for seniors in receiving proper care and supervision. So whether it's in-home care, assisted living, residential, or memory care, get the necessary advice from a senior care advisor in your area by calling Senior Care Authority at 888-809-1231, or you can go to www.seniorcareauthority.com. And I wanted to just thank everybody for all their support. We are just getting a tremendous positive input from people, and a lot of supporters who've gone on to iTunes, iHeartRadio. We're now on iBlog Radio, Stitcher, Spreaker, and of course, many of you have downloaded the free app on your iPhone or on your Android phone. And you can do, if you haven't done that, you can do so by just typing in Aging Boomers and downloading it for free, and we'll keep you up to date on all of our shows that we do twice a week. So today's guest, his name is Robert L. Kane. Dr. Kane is a graduate of Harvard Medical School and holds an endowed chair in long-term care and aging at the University of Minnesota School of Public Health, where he was formerly the dean. He directs the University of Minnesota Center on Aging, the Minnesota Area Geriatric Education Center, the Clinical Outcomes Research Center, and the AHRQ-funded Evidence-Based Practice Center. He has conducted numerous research studies on both the clinical care and the organization care for older persons, especially those needing long-term care. He is the author or editor of 31 books. We'll talk about a couple of them, and more than 480 journal articles and book chapters on geriatrics and health services research. And so, Dr. Kane, it's an honor to have you on the show, and thank you for joining us on the Aging Boomers.
I'm delighted to be here.
Yeah, and you're in Minnesota right now, huh?
It's a little cold here right now.
A little cold there right now.
5 degrees.
Yeah, so I'm glad you're indoors. That's for sure. So, boy, I we only have about a half-hour interview or so, but somebody with your background I could talk to all day. But, you've written a book called It Shouldn't Be This Way, The Failure of Long-Term Care. So is elder care in America, is the system really broken?
Oh, I think it is. I mean, basically the book describes the experience I had trying to organize care for my mother. And basically we had me, who was a pretty good care manager, and my sister, who was certainly a devoted daughter and caregiver. And my mother had reasonable amounts of money. She wasn't terribly wealthy, but she was comfortable. And with all the things that I know and all the people I know, I couldn't get the system to work to really give her the kind of care that we wanted to get for her. And my sense is if I couldn't do it, and working with my sister, we couldn't do it, I would conclude that it's probably because the system really is broken. And the system essentially is rigid, unresponsive, and not terribly thoughtful or creative about how to really develop programs that address individual needs of older people.
So how do you think this happened? Obviously, it's not something that just happened overnight, over a long period of time. I guess I want to talk about a couple things. One, any thoughts you have on how we could have avoided this, and moving forward, especially with so many boomers listening to our show, I don't want them to get too nervous, but how can we fix it? So
well, let me start with how we got there.
All right.
I mean, one of the problems was that nobody really stopped to design a system. It has evolved on the basis of financial opportunities, and the biggest financial opportunity that started it was actually the passage of Medicaid back in 1965. And when that was established, nobody had anticipated, of all the authors of the legislation, that much of that money would actually go to paying for nursing homes. And so the government found itself in this very strange position of suddenly seeing a huge growth in nursing homes and having no capability to regulate this industry. And so when you have a private industry being paid with public dollars, that generally leads to regulation. And so they rushed out and literally scooped up regulations, mostly about life safety at that point, got the blueprints from small hospitals that had been funded under a program called the Hill-Burton Act, and essentially wrote those as the regulations for nursing homes. And the people who started these nursing homes, many of them were very clever business people who found ways to essentially kite up the cost of care. And every time there was a scandal, there'd be a new set of regulations. And this sort of culminated in the mid-1980s with a Institute of Medicine report that said that nursing homes were in terrible shape and called for a broader scope of national regulations and a standardized reporting system for nursing homes. About the same time, people began to look for alternatives to nursing homes and invented a thing called assisted living. It got taken over by industry, and essentially what was intended to be an opportunity to provide people with a livable environment and services that were really created to meet their individual needs suddenly now became another money-making proposition where people were essentially selling services without actually knowing what they were doing or making clear contracts with people to use them. And so we've wound up in a very bad place through no foreordained planning, but simply drifting into this kind of a situation where entrepreneurial people have responded to opportunities.
And as I told you before we got on the air, I've been in the industry, and, one of the things that's always puzzled me, and of course this statement varies from state to state, but there are just so many people that are in nursing homes that don't, from a care standpoint, don't need to be, but because the system in many states will pay for the more expensive nursing homes, they're in there when maybe they could be in some sort of assisted living environment. Is that one of the challenges?
Well, I would go further than that. I would say that, first of all, nursing homes shouldn't exist. that they were never designed to a purpose. Nursing homes now really serve two very different markets. They serve a post-acute care, post-hospital market for people who are recuperating from hospitalizations because hospital stays have become shorter and shorter. And then they serve a long-term care market. And the long-term care market can, in fact, basically be summed up as representing three types of services. We have some kind of a housing and lodging and food service. We have personal care, and we have organized medical services to try and address chronic disease. Those services can be provided in a whole range of much more creative ways that would be much more effective than sticking somebody in a nursing home. I mean, nobody should have to share a room with a stranger in order to get a small amount of care that is what they currently get in a nursing home.
Yeah. It's so you kind of brought us up to date there. It's a little bit of a sad scenario, but that's where we are. So how do we move forward? How do we fix it? And with all this legislation and everything to get it done, what's the best way to go about it?
I think we have to look at a number of things. The first thing is that we need to develop a strong political constituency that really says that improving long-term care is an important social agenda. At the moment, there's not a politician in the country who's running for office on a campaign based around long-term care. There's no sense that there's a strong constituency out there of people who really care about this. For the most part, most people who deal with it as caregivers or family members of people in long-term care want to put it behind them as soon as that person dies. And so we don't have a sustained constituency of dedicated people who really take this as a major area for reform. Now, how would we reform it? Well, I think what we would do is we would go back and say, what are the basic values that we really want to make the lives of frail older people, more satisfactory. And if you talk to them or talk to their caregivers, it's pretty clear what they want. They want autonomy, they want dignity, they want respect, they want compassion, and they want choice. And we ought to be able, in a country as creative as this country, to think about ways in which we could house people together in places where they could live to make the services more efficient, without forcing them to live in shared rooms with strangers. We have apartment houses that work very well. We can have a whole series of small apartments where people could live. We also have a problem because we have taken on this idea that all frail older people are socially dependent and can't be allowed to make decisions about what kinds of risks they're willing to take for their own lives. And I think this is a big mistake. There are many older people who would much prefer to take the risk of falling once in a while if they could basically manage on their own and be much more independent. We insist on doing things for people, and as a result, we make them more dependent.
Yeah. So, boomers, they're been turning 65 years of age now for, I think, a couple of years now, and more and more. We're dealing a lot with their parents, but the boomers are getting up there. What should they be concerned about?
Well, the first thing that boomers need to understand is if they're going to change the system for themselves, they have to change it now while they're advocates for their parents. By the time you become frail yourself, you're much less effective as an advocate. And so now is the time to really begin to push for the kind of reforms that we want to get a livable long-term care system. And it isn't that hard once we get together to recognize, what needs to be done. Now, what it involves is obviously, making dramatic changes in the way we do business with regard to delivering long-term care services. We have dramatically over-professionalized long-term care. We require that the people have all sorts of training that they may not no longer need as much as is mandated, because we can use other kinds of support systems like computers to instruct them and guide them in what they do. We can be more flexible in where they live, and we need to find ways to basically coordinate the medical care with the social care, and that's done by developing organizations that share a set of common goals. So we can reinvent long-term care if there's a political will to do it. Now, the boomers at the same time as caregivers go into caregiving totally unprepared for what they're going to face. And so after I wrote the book about my experience with my mother, I wrote a second book which really is designed as a survival guide for caregivers. And it's called The Good Caregiver. And The Good Caregiver basically is a book that tells people who have never been caregivers before, which is most people who are taking care of older people, what they need to know in order to effectively advocate and organize care for their older parents or relatives. And what that means is that the caregiver basically takes on the role of case manager and of advocate in order to make sure that older people get the rights and the services they're entitled to. It means that that they need to know how to make informed decisions about what are the range of alternatives that are currently available to older people, so that they don't get simply put into nursing homes.
So when we started the conversation, we were talking about nursing homes and how when Medicaid started back 65, I think you said 1965, that there wasn't they didn't think that there was going to be so much money having to be paid out into nursing. Okay, so as it relates to government's participation in a newer system, should we be fortunate enough to get it to change. What do you feel government should pay for and could pay for? Is it still the medical side of things, or could they be paying for other types of services like what we classify more as assisted living today?
Well, I think we have to get out of this mindset that there are two kinds of money. There's public money and private money. It's all money. And so the question is basically, how do we organize it in a way so that people can afford the things that they truly need in order to get the kind of care that they truly want? And so I'm convinced that we're never going to have a system that's going to be very effective that's going to depend on individual saving. I mean, people just simply are not capable of doing it. The costs of living today are such, the incomes of so many people have been stifled, that it's unrealistic to expect that they're going to either save money or have disposable income that they can use to buy private long-term care insurance. And so we're going to need some kind of basic government program. And the government program, basically needs to address the three components of long-term care. It needs to address the room and board component, it needs to address the personal care services component, and it needs to address the medical services component. Of those three components, the room and board component is probably the most flexible in the sense that obviously people who do have more money can basically afford a nicer place to live than people who don't, just as is true of people of all ages. And I think that we would want to provide a minimum level of amenities for people living in the community receiving long-term care, but we also would allow people to pay more money and live in more opulent surroundings if they could afford it. The services components, I think, should be universal and should not be based on income, but should really be based on the needs that people have for this kind of care. And most people do not make extraordinary demands on the system that are inappropriate for the kind of services they need. In fact, most people are actually underserved.
What role is dementia playing on the whole system from a cost standpoint? Is that the big part of this? Because people are living longer, and we're hearing more and more people, even at younger age. When I say younger, I'm talking in their 50s and 60s, and being diagnosed with some form of dementia, and that certainly takes its toll on the family and on the system. How is that playing a part as we age in America?
Well, I mean, dementia is an enormously devastating disease that's associated with aging. The majority of dementia that we have, Alzheimer's disease, basically occurs at much later times in life. I mean, the rates at 65 are down, in sort of the single digits, around 5%. By the time you get to 85, you're looking more at like numbers of 35 to 40% of people with Alzheimer's disease. So it's very much an age-related phenomenon. There are unusual cases of dementia that present at a much younger age, but they're atypical, usually associated with strong family histories of dementia. Now, dementia is a devastating disease for all sorts of reasons. I mean, one of them is, of course, that the person doesn't look any different. They're not enfeebled, they're just confused and develop behaviors that may be incredibly annoying and troublesome to the people who have to care for them. And so they require a great deal of of time and attention. They require a great deal of tolerance because people, with dementia tend to repeat the same things over and over again, and so you become impatient with the repetitions. And in some cases, they may get aggravated and become aggressive, and that can obviously be dangerous for everybody. Sometimes it's just verbal aggression, but sometimes it's physical aggression as well. And so dementia takes a huge toll out of the caregivers, and the vast majority of those caregivers are family members. And we need to appreciate how absolutely critical family caregiving is. I mean, when you look at the entirety of long-term care, somewhere between 85 and 90% of all the care that's given for long-term care is given by family members. If we ever stopped that, we'd be in terrible shape.
And let's talk about that, because like you mentioned before, you recently wrote a book specifically to help caregivers of the elderly. It's called The Good Caregiver. Talk a little bit about the book. Talk about how family members can educate themselves to help in taking care of family members, because as you mentioned, it's not like any of us have much experience at doing this. Once they're confronted with it, it's kind of like jump in and learn how to swim,
Well, it's very much like that, unfortunately. And so let's start with the very basics. I mean, the first thing is that very few of us know what our elder parents' situation really is. There's no single place where you can find all of their, financial information, all of their bank accounts, all of their investments, or their insurance policies, and then in many cases it may be hard to access those resources because the younger person has never been listed as a co-signator on some of those accounts. So one of the things is that ideally you want to really begin to plan ahead. And I recommend that every older person ought to have a 3-ring binder, and in that binder ought to be a list of all of their bank accounts, all their insurance policies, all their Medicare information, all of the names of their doctors, and other dentists and other kinds of people that are important in their lives. Because as the caregiver begins to take on the responsibility for this, they become the coordinator. Now, the average older person, for example, may see somewhere on the order of 8 different doctors over the course of a year. None of those doctors know what the other doctors are doing. And so they may be prescribing drugs that interact with one another. They may be duplicating prescriptions. It's the responsibility of the caregiver to really serve as the case manager and make sure that the other doctors understand all of the diagnoses that the person has and all the drugs that they're taking, and to make sure that they develop as reasonable and rational and as simple a drug regimen as possible, because we get into all sorts of problems from just over medicating people by people laying on one set of drugs over another. I sometimes use the example of when you were a kid in school and every teacher gave you homework like hers was the only class you had. Well, we tend to prescribe that way. And I think we need to be very careful about that. There are studies that suggest, for example, that managing diseases one by one for people that have multiple simultaneous chronic diseases, as most frail older people do, can actually do more harm than good. And so you need to understand the context of all these diseases and what they are. You need to be an advocate for older people in terms of determining what it is they want, and what are their life goals, and to what extent is aggressive care really in their best interest all the time. There are critical decisions that you need to make at various points. One of them is when you think it's time for somebody to get long-term care. And the whole process of decision-making, which often is tied up with a discharge from a hospital, is a national disgrace. I mean, when you think about, making this major decision that requires a great deal of thought, requires examining, what are your goals for the outcomes of, what it is you're trying to, improve or maintain the most, this requires some time and some thought. If you think about making it inside a family context where the family members may not agree, or they may have a history of not agreeing with each other around a whole bunch of things, it becomes an incredibly complicated system, not only to be rational, but to be emotionally in charge. And so making these decisions needs to be done with a lot of assistance and support, and it can't be done in a couple of hours when somebody says, we're going to discharge you by 5 o'clock this afternoon.
Exactly.
Now,
right. Yeah.
When you make these decisions, we recommend that people break down the decisions into 2 separate components. The first component involves defining what it is that you're trying to maximize. What are the goals that you have? Are you most interested in trying to maintain function? Are you most interested in trying to keep people safe? Are you most interested in simply trying to give them a reasonable quality of life? And each of those decisions then may have implications for what's the best type of services available. Now, most people are not aware of the whole range of long-term care services that you can get, but there is a wide range of services, some of which are delivered in the home, some of which are delivered in places like assisted living, some of which are delivered in places like nursing homes. In some cases, you may want more active formal rehabilitation in what are called inpatient rehabilitation facilities or outpatient rehabilitation facilities. In some cases, you're talking about something more like hospice care. And so you need to decide which type of service is most appropriate to maximize the goals and the circumstances of the older person that you're talking about. And then, once you've determined that, then you make the second level decision, who's the most appropriate vendor for that. Now, the first decision is going to be based on what type of care is most likely to produce the desired outcome. The second decision is really going to be based on other kinds of things, which would include things like the accessibility. Is it near places where you'd be able to visit? The amenities. Is it a place you really like to live? The quality. What do we know about how good it is? And very often the cost. And so this is a very structured, there's a need to be very structured in the way we make these decisions, and I strongly advocate that people basically get help in making those decisions, because the people that they're most likely to rely on aren't necessarily their advocates. I mean, most of the people look to the so-called hospital discharge planners as people who are going to help them make the best decisions. But the discharge planners work for the hospital, and the hospital has basically told the discharge planner, this person has to be home, by close of business today. And so the first train leaving the station is the best one to be on. And that's not in the patient's best interest. And so, hiring an independent care manager who understands the territory, who knows what your rights are, who knows that they can't really throw you out of the hospital at 5 o'clock, that is terribly important in order to give you the time and the information that you need to make an informed decision.
Yeah. As I mentioned early on, I could talk to you all day about this subject matter, and you've been a wealth of information, but unfortunately we're out of time. So I want to make sure before we sign off, you could let our listeners know how they could learn more about you and what you do and your books. How would they get that information? Well, two things. You can certainly Google me. Mm-hmm. It's Robert L. Kane, Kane, at the University of Minnesota. And you'll find a whole bunch of stuff. But I would urge anybody who's in the process of becoming a caregiver or thinking about the likelihood to be a caregiver to get a copy of The Good Caregiver. I mean, I really did write that as a survival manual because caregivers are critical to the well-being of older people, and they are, unfortunately, coming into this without any training or preparation. So if you get a hold of The Good Caregiver, it will give you a step-by-step approach to the things you need to think about in order to be an effective caregiver. Dr. Robert L. Kane, thank you so much for joining us. We got to have you back. There's just so much to discuss. And thank you again for being on the Aging Boomers, and thank you all for listening in. Again, feel free to pass on the information to friends and family, and you could do so by just sending them the links at theagingboomers.com, or of course you could go on iTunes. You could go on iHeartRadio, do the same. So share the information, a lot of good information. Be safe out there, and we'll talk to you all soon.